if you want to make a go of it in rural America, if you know anything about the demographics of rural America,
Sure.
there's that the payer mix is high government funded payer mix. So one of the advocacy efforts that we have right now in Washington, D.C. is related to CMS recognition. The only exception is that during the public health emergency, we got a waiver. So we have 3 years where we were allowed to participate in Medicare. But other than that, CMS really has said, we don't know what to do with you. You're not tied to a hospital. So we only get reimbursed from commercial insurance. So that limits us from going into rural areas.
You would think that after 3 years of, success, as a temporary waiver, whatever for the emergency, but after 3 years, okay, it seems to work out. Why not just make it permanent?
That is the story that we're telling. And we have some really Medicare's own data. You say that it worked out well. It worked out exceptionally well. What the 3 years that we participated, obviously there's concerns when you introduce a new provider type, if you will, that the government's funding, that utilization is going to increase and it's going to drive up costs. And that's a valid point.
Sure.
What the results showed, though, was there was no increased utilization. There was just a shift. So instead of grandma and grandpa going to the hospital-affiliated ER, they came over to state-licensed FECs like ours. And equally compelling is it showed that the cost per episode of care, severity adjusted, so comparing like patients, acuity patients, that we were over 21% cheaper per episode of care in the ER, cheaper. Even we were getting paid the exact same amount per test, right? Per visit, per CPT code, but we just ordered fewer tests. And then we were also significantly less likely to admit patients.